Hello, my colleagues. Let's start our new mixed cases session today. I'd like to give you two pieces of advice before starting. Please, now I think about 2 months is remaining, exactly 2 months is remaining from the January exam. Every one of the candidate of January must make a little bit of evaluation for himself and rewrite the mistakes, the drawbacks, and the weak points, weak systems, and they try to concentrate on it. All of you are doing a great effort now, as I expect from all of you. But the most important is the weak points. Why? Because the 4 or the 60-minute oral Viva session is very, very well structured. In other words, it is divided to cover most of the systems and most of the modalities with different uh, degree of difficulty and a different way of question. Like one examiner will give you something easy, other one will give you something difficult. One examiner will give you a case with a subtle finding, another one with a long case scenario. So um, many or some of your weak points you will face inside the exam. This is a true experience. Okay, my colleagues. So from now, we will have 60 days. It is very, very enough period to
ايه
improve, very enough, more than
ايه
enough period
لا عادي ما فيش مشكلة.
to improve any weak point, and this is the target. After that, after passing the RCR, you can change your way, you can choose cases that you are love or your subspecialty. But now, in this from today, the 6 days, concentrate too much in the weak points. I will give you two weak points. I guess most of us has it. Number one, some subtle finding in the X-rays. You must. I faced it twice. I faced it twice. Subtle finding in X-rays. Number two, the unfamiliar cases, not cases, examination like spine, like what, like brachial plexus, even the basics of this. Okay, my colleagues, um, I hope all of you get the point that I just discussed now. Let's start with our first candidate. You can ask control. Hello, Dr. Nam, can you hear me? Hello, hello. I can't listen your voice, Dr. Naham. Unmute yourself, please. Hello. Hello, candidate one. Hello. Hello.
We lost the screen.
Hello. Can you listen me?
Yes. Hello. Yes, now I can hear you. Yes.
From which point you lost my voice? Dr. Naham. Hello. Hello.
So yes, sir. Yes.
Can you listen me
Yes.
now?
Yes, now I can. Yes.
Yeah. At which point you lost my voice?
So when you were asking me to request for the remote control. nothing
Yeah,
more.
I prefer to I will scroll for all of you because last time يعني, two candidate make something wrong, so they shift directly to the answer, and I think this is disturbed the session last session. Okay,
Yes, better.
okay. So I will scroll through of you. It is better because the cases of today is very precious, and I hope all of you think about it and tell the maximum of details. Let's start. First case, 2 years old male patient presented with history of nausea, vomiting, ataxia, lethargy, and seizures.
Okay, so I'm presented with a child 2 years of age with neurological symptoms for 1 month. I would like to have a general look before starting my comments. Okay, so I can see that there is a right-sided VP shunt with no significant hydrocephalus on the current scan. There is an abnormality involving the posterior cranial fossa and the right temporal lobe in form of heterogeneous high-density gyri bilaterally, almost symmetrical. There is increased CSF space on the bifrontal region. I would like to check the other planes and the post-contrast for further delineation of this lesion. Okay, so this is the coronal. Okay. Yes, again, the VP shunt is in place. The abnormal high density gyri are again demonstrated. The widened CSF is noted. Increased density of the superior sagittal sinus. I'm concerned about sinus thrombosis in association with the mass on the posterior fossa. There is no high density within the subdural spaces to suggest hemorrhage. I would like to check the bone window to check for any fractures being the cause of this subdural collection. There is increased hypodensity of both cerebellar white matters denoting edema.
Yes, what else?
Okay. Can I check the post-contrast, please, to check for any underlying lesions?
The axial one
Yes.
was the post contrast.
Okay, yes. Okay, so on the sagittal plane, I would like to check for any tonsillar herniation, which I can see. So this is an emergency. The upper cord is heterogeneous with areas of low density. So my differential diagnosis, no focal enhancing lesion. Given the age of 2 years and given the long duration of the history, I will be thinking about congenital masses. My top differential is the teratoid rhabdoid tumor.
Okay.
Other congenital tumors, however, should be enhanced, like medulloblastoma and choroid plexus papilloma, yes, carcinomas, papillomas. These
Yes.
are congenital, however, enhancing, and there is no hydrocephalus to suggest. No, yes, the fourth ventricle is compressed with no internal masses. There is no calcification within these lesions.
Yes, what is the
So I would
next
like to
step?
proceed for MRI.
Okay.
This is the post-contrast. Yes, showing. Okay, so there is increased enhancement of the meninges, the leptomeninges, and the pachymeninges on the region of the basal cistern. Again, demonstrated the heterogeneity of the posterior cranial fossa. The sinus appears unremarkable. However, I would like to check it on the CVA, MRA. So, meningitis is okay. The CP angles are clear. Meningitis also coming into the differential. I would like to check for any focus of infection. The mastoid air cells are clear. The sinuses are, I would like to check the sinuses.
What do you think?
Okay, sinuses are clear. So,
Hmm.
yes, I will be thinking about one of the congenital masses
Yes.
with meningeal involvement.
Mm-hmm.
Again, the atypical thyroid rhabdoid tumor and the medulloblastoma. Craniopharyngioma is not typical in this case.
Hmm.
I would like to check the whole neural axis, the spinal cord, to look for any drop metastasis.
Okay.
Would like to, yes.
Hmm.
Yes, can I check for the diffusion?
Diffusion. This is diffusion.
Yes.
What do you think? Final
Yes, it is.
diagnosis? Hmm.
Yes, it is bright on the diffusion. I would like to correlate with the ADC.
Okay, EDC, it is a true diffusion restriction.
Okay.
So your final,
Yes, medulloblastoma is showing diffusion restriction. So, yes, could be medulloblastoma. Again, would like to check for the whole neural axis. This is emergency to CSF analysis, biopsy, histopathology, MDT meeting discussion, and accordingly managed accordingly.
thank you so much, Dr. Anagam. You were amazing. My voice is clear or interrupted?
Yes,
Okay.
no, so clear. Thank you.
Thank you so much. The answer is disseminated medulloblastoma, but associated with superior dural venous sinus thrombus. What happened? Take some home message, doctor. You start very well and you forget during this axial one that is post contrast. So you ask for post contrast. So to take care from this fine point. Look here to the vessels. Look here. The vessels contain contrast. So it is axial post contrast. Number two, you mentioned the CP angle are clear. No, masses. There are large masses here. Number three, at some point, at one point, you mentioned that it may be meningitis. No, meningitis can't be presented with these large masses. These large masses. Look here, large masses here with calcification. Okay? Because if this a meningitis, the patient will take antibiotic, but this patient need a chemotherapy. Two different pathways. So take care from this very, very small mistakes. Number three, here you suspect in superior sagittal sinus thrombosis, but when you came to the MRA, you retake your or you remove your diagnosis of superior sagittal sinus thrombosis, despite the MT delta sign or MT sinus sign here. This is not enhanced. Okay. So it was a case of medulloblastoma, okay, with lepto and even pachymeningeal spread. And look here, this is bilateral subdural collection. This case may confuse somebody with non-accidental non-accidental injury. Sometimes, if you lose the type of sequence, this is post contrast. Okay, this is not normal T1, so this is the enhanced method. So knowing the technique and the sequence is very, very essential. Okay, look here, my colleague, in these annotated images. Look, this sinus is thrombosed. Look here also, thrombosed sinus. All of this. This also cortical thrombosis. This case may be presented for you as a long case, so you must mention all of this. You must use the SWI, especially if the examiner give it to you in long cases. Okay, look here. Look, to this subdural collection. Look here to T1 hyperdensity here. Very nice case fail of finding. Okay, my colleague, even here, this is a foci of hemorrhage. Anyway, it was a case of disseminated medulloblastoma with superior sagittal sinus thrombosis. Okay, my colleague, this is the answer. Thank you, doctor, so much. Next candidate.
Candidate 3, please proceed.
Sir, am I audible, sir?
Yes. I will scroll because last time many candidate has seen the answer and it was not good.
Okay, sir.
45-year-old female patient presented to the ER after motor car accident.
Okay, sir. I am presented with axial contrast enhanced CT scan of chest and abdomen of a 45-year-old female presented with early history of motor vehicle accident. I would like to go through the entire sections before I start commenting. In chest section, I could see right moderate pleural collection, and in the abdomen sections, I'm taking a moment to see for abnormalities. I can see there is right perinephric fluid collection, and I cannot see any obvious splenic injury. I can see there is a linear laceration involving the upper pole of left, superior pole of spleen. However, it is not extending into the hyla, and there is no obvious contrast leakage. But however, I would like to see the arterial phase for obvious contrast extravasation. And the liver parenchyma appears to be normal. And I would also like to see the pancreas to look for any other injuries. And I would like to see the lung window for any associated lung injuries, pneumothorax, or any
Where is the
other
lung window?
lung. In axial CT chest lung window shows there is right right pneumothorax with the air fluid level representing possible pneumothorax and hemorrhagic fluid. But however, I would like to measure the HU value to confirm the findings. In my routine practice, I will also see the bone window to look for any associated fractures and associated rib fractures and vertebral fractures. So that screen is getting stuck in between.
Sorry, you can check the bone here from here because other sequences need time to download.
Yeah. Yeah.
What's your diagnosis?
Yeah. So my final, I can also see right left ICD tube noted within the pleural, going into the pleural collection. So my final diagnosis is splenic injury. I would like to measure the laceration size to grade injury, and it appears to be possible grade 2 or 3 injury with the right left with the perinephric collection, and also left pneumothorax and hemothorax. And so I would like to convey my findings to the referring physician, and Grade 3 liver splenic injury can be do as a conservative management. For hemopneumothorax, ICD tube insertion can be done.
Do you
Um,
want to see anything else?
Pardon, sir, I didn't get you.
Hmm?
Can you repeat? Can you repeat again, sir? First.
Do you want to see anything else?
In I1, also like to see the abdomen in lung window to look for any pneumoperitoneum, sir.
What else? What else
And
do you want
I
to
would
see?
vertebral fractures also I would like to see, sir. Any edge compression fractures that also
What else?
in,
What else?
uh,
Hmm.
other solid organs appears normal and delayed phase also to look for any renal injuries, bladder injuries also, sir.
What else?
Mhm. I'm not sure, sir.
Okay, do you think the examiner will give something simple like this? What do you think about this? Are you sure about this lesion?
Yes, sir. In coronal, I would like to see the same in coronal section to look for any diaphragmatic injuries, sir.
What do you think? If the examiner refused, the examiner told you no, it's very sufficient to diagnose or differentiate between diaphragmatic hernia or whatever. What do you think? There are any clue here?
Mm.
What is this?
Yeah,
See, what is this?
stomach. Yes, sir.
What is it?
And
What is this?
bowel loop, sir. This
Why?
bowel loop.
Is this cyst tube?
With NG tube, nasogastric tube probably, sir.
How many tubes you have in
Yeah.
the left hemisthorax? How many tubes?
Yeah, yes, sir.
You have one. This is
One,
the point.
I see.
Yeah, this is the point of
Intercostal
confusion.
drainage. Yeah,
This
yes,
is
sir.
one,
Intercostal drainage tube is there, and
and this is
another
another
one is
one.
coming. Yes, sir. Yes, sir.
What is this? Follow it, please.
That.
Follow. If you follow it,
Yes, sir. Yeah.
what is this tube? What is the name of this tube?
Yes.
Hmm.
This can be. This can be nasogastric tube and
Yes. Look
due to
here.
rupture.
Yeah. Look here.
Yeah.
Look. And this is a continuation. So, what's your diagnosis?
Yes, sir. So my final diagnosis is there is diaphragmatic rupture with a herniation of stomach into the left thoracic cavity.
Yes.
And also left splenic rupture. Sorry, sir, not splenic. Left splenic injury, possibly grade 2 to 3.
Yes.
Also
Great.
left.
Yes. Yes.
Also
See, my
left
colleagues,
one.
this tube, this
Yes, sir.
spontaneous with the esophagus.
Yes, sir. Yes, sir.
Okay? This is the
Yes, sir.
tricky point. But this tube is intercostal, directly
Intercostal.
intercostal. Okay? A big
Okay.
difference. And it was very confusing point, but by the way, very confusing
Yes.
point. What happened here? Look here. In the axial, some examiners insist that no sagittal, no coronal, but you must ask.
Okay.
At least you didn't ask. Number one, what happened here? The patient is trauma, and
Yes.
this is a laceration. I think it reaches the hilum, okay, but not a big deal because there are no obvious extravasation. But
Okay, sir.
the disaster is here. air fluid level, looks like hemopneumothorax, and this looks like the part of the chest tube. But look here,
Yes, sir.
chest tube end here, ended, and we started another tube here. Follow it,
Okay.
please. Follow this. Follow this. It will be inside the esophagus. Okay?
Okay, sir.
Very,
Perfect.
very tricky case. It was
Yes,
difficult.
sir.
Okay?
Okay, sir.
Look here. This is our tube. If we follow, look, this one. So it is
Yes.
nasogastric tube. So this is the stomach. So this is at least rupture. And look here, this is the neck of the diaphragmatic hernia. This one, this is small one. So a small neck is very, very predisposing sign to strangulation or other complication. Look, very small here. Okay. So the first thing, this patient needs a surgical correction, urgent surgical correction, because this is diaphragmatic rupture. And there are many other minor finding here. We can mention about it, like here. If you look here, you feel like there are some biliary dilatation. If you go down, you will find something between the pancreas and the duodenum. Where is the pancreas? Head.
Oh,
This one. Okay, if you look here, there are some thickening in the duodenum and there are some hematoma here, something like this. Look, see
okay,
how
sir.
much thickened
Yeah.
the duodenum. It is a minor finding, no problem. Uh, Take care from confusing uh, items like two tubes like this. Last case also, we confused between is it hemorrhage or is it enhancing lesion in the brain. So confusion may be a challenging factor in our exam. Thank you, doctor, so much.
Okay.
I think
Thank you, sir.
most of the bone are normal. Thank you so much. Next candidate.
Hello, sir.
Hello. Doctor, this patient presented with abdominal discomfort.
Sir, shall I ask for remote control or?
No, I will scroll. You can stop me at any slice.
Okay.
Go on.
So I have been presented with axial CT images of an chest and abdomen of a patient who is presented with a complaint of abdominal discomfort. I will have a quick look through the whole set of the images before I comment my finding. Um, okay, so I can say there are multiple diverticuli noted within the sigmoid colon region. There is a diffuse wall thickening is noted at the region of the sigmoid colon, and there is also adjacent fat stranding is present. It is a long segment. I would like to see the adjacent area to see if there is any evidence of diverticular rupture or any abscess collection formation. Oh, so I can say there is thickening is also noted within the urinary bladder. I'm thinking of there is a fistulous communication with urinary bladder of this sigmoid diverticular disease. So there is a colovesical fistula.
Okay.
However, there is no any abscess collection is noted adjacent to this. Apart from that, there is left-sided hydronephrosis is present,
Yes.
and the ureter is also dilated,
Mm-hmm.
and it is also involved in the adjacent fat stranding due to diverticular disease.
Yes.
I'm looking on the.
Mm.
So I would like to see the any post-contrast images to see if there is any venous thrombosis to exclude any venous thrombosis,
Excellent.
and also liver abscesses. Uh,
This
the
is
spleen appears to be
the
large in size,
okay. What else?
and the liver, I would like to see the liver, the right lobe of the liver appears shrink in size.
Yes. What else?
The diverticular disease also involve the ascending colon and the okay, so it is also involving the descending colon.
So what's your final diagnosis?
So there is a significant diverticular disease with a sigmoid with a colovesical fistula and also infiltration into the left ureter, involvement of the left ureter, which in turn leading to a hydronephrosis and hydroureter. So I will immediately convey my finding to the referring physician. This require a urology workup for percutaneous nephrostomy and also require a gastroenterology referral for urgent management and also correction of the fistulous communication between the urinary bladder and the colon.
Thank you,
And
doctor, so
after,
much. Thank you so much. But don't forget this thrombosis. Okay. You ask
okay,
about, I will see the coronal or whatever, rule out thrombosis, but you told me and you didn't search. Take care. Okay.
okay, sir.
Don't talk about finding and finally you didn't search sure about it. The liver is cirrhotic, the spleen is large. What happened here, my colleague? This is not diverticular, this is diverticulitis. Okay? Diverticular is a general term. May include diverticulosis, which means that there are no inflammation, but here there are fistulizing diverticulitis. Diverticulitis, which ruptured and see, make something here and make fistula with every structure beside it, with the urinary bladder, okay, with the ureter, at least fibrosis around the ureter, because there are, I think, no any gases in the ureter. Okay, so it is at least obstructing the ureter, and here I think there are with this small bowel. So it is markedly infiltrating or fistulizing diverticulitis. Okay, it need a surgical interventions. Besides that, there are thrombosis of the SMV and convolutions. Look here, partial thrombosis. SMA, SMV, sorry, and the convolutions, venous convolutions. Thank you, doctor, so much. The answer is here. Chronic fistulizing diverticulitis. Why chronic, doctor, not acute? Why?
Sir, because of adjacent fibrotic changes.
Yes. Which fibrotic? Which pathology of those is sure fibrotic?
Um,
It may be fistulizing during the acute phase. This is logic. But the hydroureter.
okay.
So I insist that the ureter there are no fistula, but just obstruction. Why? Due to fibrosis. Thank you so much, doctor. Next candidate.
Yes, sir.
Welcome. This is an
Thank you.
important case. This is typical case of the exam. I mean that some of our friends has been presented with this case. Exactly 20-year-old male patient presented with 6 months history of painful right mid-chin lump.
Okay, so I have been provided with a plain X-ray of the right leg, frontal and lateral views. I can see here there's diffuse sclerosis affecting the tibia, including the proximal tibial shaft and extending to the mid shaft, as well as the knee articulation. I can see that the
Again,
lesion
please.
appears with.
No, again, please.
I can see there's diffuse sclerosis
Where?
affecting the tibia.
Where is exactly in the
I
tibia?
think the proximal and the mid tibial shaft and extending to the articular surface.
You may ask
Um,
control, please.
Yes, I will ask for control.
Hmm.
I requested control, sir.
Yes. Show me, please, exactly where.
Can you see my pointer, sir?
No. Move.
Here, can you see my pointer?
No. Where exactly?
I'm moving my pointer right now.
No, nothing. Ask
Here
you.
you can see,
Yes.
sir.
Yeah.
Now you can see,
Slowly.
sir.
Yeah. Where?
Okay. So I can see there's diffuse sclerosis here affecting the tibial shaft.
No.
You can't see my pointer, sir.
I see your pointer, but
Okay.
this most of this area is normal. Where is
Okay.
exactly the area of abnormality?
Okay, sir. I can see here there's cortical irregularity here.
Which part? Medial, lateral, upper, lower? Give me in some buzzwords.
Okay. I can see there's cortical irregularity seen along the medial cortex of the tibial shaft.
Lateral or medial?
I think it is medial, sir.
Okay, thank you. Okay, what will you do next?
I think this lesion is of aggressive nature.
Yes.
I think it's of permeative nature. So I think it is an aggressive bony lesion.
Mm-hmm.
I'm thinking about lymphoma or leukemia regarding the patient's age, as the patient is 20 years old.
Mm-hmm.
I'd like also to see the lateral view to correlate these findings on the lateral view.
No. See. You ask and
Okay,
I will give you. Don't leave the
okay,
mouse,
thank you.
please. Yeah.
I
Okay.
left the mouse,
So,
sir. Okay,
okay.
okay,
What
thank
is
you.
your next step?
I also can see an ill-defined soft tissue lesion surrounding the very osseous soft tissue shadow. So in my next step, I'll ask for an MRI of the leg to see to better appreciate the signal intensity of the lesion and to see if there's any extra osseous soft tissue component.
Mm-hmm. So, what will you do?
I'll do MRI of the leg, sir.
Okay. This is MRI.
Okay, so you will scroll, sir.
Yeah. What happened?
So I have been provided with the MRI of the same patient. I can appreciate that there is a low signal intensity lesion affecting the mid-tibial shaft. Um,
Mm-hmm.
Can you scroll again, sir, to better appreciate the remaining part of the lesion?
Scrolling? Yes.
Yes, can you scroll, please? I
Yes.
can appreciate that the lesion is of permeative nature. It covers the long length of the tibia. I think also
Mm-hmm.
there is a periosteal reaction here in the cortex, in the tibial cortex. There is a step-like deformity of the tibial cortex here in this cut we are seeing now. So I'd like to see if there is fat suppression or if there is T1 contrast to fat suppression to see if there is any enhancement. Here I can see there is intramedullary enhancement, and there's cortical breach with the extra osseous soft tissue component. There is enhancing extra osseous soft tissue component. Here in the axial view, I'd like to better appreciate it in the sagittal or coronal views.
This is enough. What's your final diagnosis?
Okay, my diagnosis for this case would be an aggressive bony lesion of the tibia. with the periosteal reaction and extraosseous enhancing soft tissue component. I'd like to
Mhm.
correlate these findings with the patient's history. My differential diagnosis would be inflammatory acute inflammation such as acute osteomyelitis or an aggressive bony lesion such as leukemia or lymphoma. So I'd like to
Okay.
ask for the patient's history.
Why not osteosarcoma? The patient age is patient young age. Why not
As
osteosarcoma?
and yes, might be osteosarcoma also. However, the permeative nature of the lesion somehow directs us to the other diagnosis. However, the osteosarcoma is also not included in our differential diagnosis.
What is in your top of differential diagnosis and why?
My top differential diagnosis would be I think owing to the low signal intensity of the lesion, I think it would be lymphoma or leukemia. Then I'd include the other lesions such as osteosarcoma. Also, as I said before, I'd like to ask about the patient's history of any acute pain or acute presentation to exclude the acute osteomyelitis.
Do you think osteomyelitis should be included here? Look again.
No, I think it should be on the last item on the list, I
Okay.
think. So
Thank you, doctor, so much. What happened here? When you are talking, don't make the examiner ask you to point. Try to escape from this question. So give him exact locations. Doctor, I can see cortical thickening in the upper and the medial shaft of the tibia. Because
okay, and
when
my first
he
glance, yes,
yeah when he
I thought it would be permeative. Oh,
no, you do like this means you missed it completely. Why? Because the only finding here it was this one. See?
okay,
Exactly from here, this one, just
yes,
cortical thickening. But when you do like this, the examiner will kill you immediately. Big difference from see, you saw the MRI, big difference, just some cortical soft tissue. Okay, what happened here, my colleagues? And these cases is very common, very common. I'm not telling like this to threaten you, but to be familiar with these cases. I mentioned many times when you are presented with a bone X-ray and it look like unremarkable. Look at two items at least. Number one, to the cortex. Any periosteal reaction or any cortical thickening. If you didn't find anything, look at the density and compare if it is bilateral, compare bilateral. If it is like this, compare here by here, up and down. You must find something. Number three, if you didn't find anything, look at the soft tissue. If you didn't find, ask for other orthogonal views. Okay? There are no any associated mass here. So don't tell findings that especially not present. This is if the finding is not present, this is a mess. Okay? What happened here? We did MRI. And what happened? We find just infiltrating inside the bone marrow, inside the bone marrow, and there are cortical erosion or destruction, and with a small extracortical extension. Okay, the degree of aggressiveness of this tumor degree is very mild. Okay, despite it is not so small. So it is one of the most important criteria of the lymphoma. Look here, all of this, plus the transverse part. I'm waiting from you to tell me, doctor, I would put the diagnosis of lymphoma at the top because there are a disproportion between the size of the tumor and the cortical destruction. or the degree of aggressiveness. It is very important buzzword. Look again, here from here to here, all of this, plus this one, and just very small cortical destruction. Okay, very important buzzword. Look, the disproportion between the size of the tumor and the destruction means lymphoma. Thank you, doctor, so much.
Sir, excuse me. I have a question about the radiograph, the X-ray.
Yes.
When I saw it first, I noticed the cortical thickening. Why it is not osteodyostoma?
Leave the mouse, doctor, please. Or please. Why? I should ask you this question. Why?
Because
Why?
osteodyostoma can cause similar appearance, which is cortical thickening. And
Look here. Do you think osteodyostoma will take all this length? And there
I
are
mean, if there is no
intra.
lateral.
Yeah, yeah. No. He asks the lateral, and I give him the lateral. Look here. Look here, please. If you see here, there are intramedullary sclerosis here. Okay? And there are large lucency here. The lesion, our lesion of, at this X-ray, see, I will just start from here in the lateral. Down, look, including this intramedullary. Do you think the osteodyostoma may cause this large area of abnormality? And even if you told me, doctor, it may be osteodyostoma, great. You pick up something. He told me this is aggressive and I will do MRI. Okay. At least this case was a case of a little bit subtle finding. Did the candidate pick up it or not? Can you answer me?
Yes.
Why? In your normal practice, you see this X-ray and you write it as normal. Your friend write it as osteoma here, or your other friend write aggressive lesion here. Normal is a disaster. Others is good. The best is the more accurate, okay, but in X-ray it is very difficult to pick up from the beginning the most accurate answer. Are you agree with me?
Yes, of course.
Okay, next one.
Thank you, sir.
Welcome. Next.
Yes, sir.
This is 40-year-old female patient presented with menstrual abnormality of the lower abdominal vein.
Okay, sir. I'm provided with the axial MRI, T1 post contrast of the pelvis.
Are
Okay,
you sure this is post contrast? Are
sir,
you sure?
uh,
Are you sure?
sir, can you, sir, sir, it's T1, sir, T2 FS, sir.
Okay.
Yes, sir. Okay, sir. I can appreciate that endometrial cavity is distended. It's distended with the low signal
Mhm.
area. The bladder wall is normal. Sir, can you scroll for me? Further? Sir, the rectum is normal. I can appreciate this. Mm, uh, the bladder is normal, sir. Uh, on going to the lower sections, the vaginal canal is normal.
Mhm.
Sir,
So,
sir,
mhm.
I can appreciate an abnormal tubular structure is lying in posterior to the uterus. Sir,
Which one, T2?
Yes, sir. I would like to see sagittal T2, sir.
This sagittal T2.
Okay, sir. There's hyperintense area signal noted. She's lying posterior to the uterus. So the uterus shows uh, hyperintense signal. Endometrial cavities shows hyperintense
Look here,
signal.
doctor. What is this?
So this is a axial T1, sir. So, sir, this is a tubular structure. It's a blood, sir. It's a T1 hyperintense signal. So, sir, it's possibly blood, sir. And it's a
Mm-hmm.
tubular structure, sir. It's growing on the right side, sir. So it's
Mm.
sir, fallopian tube,
Mm-hmm.
sir. So it's a hematosulfing, sir.
What else? Look here, I will help you. What happened here?
Actually, sir, it's blood in the endometrial cavity, sir. It's not in the fallopian tube, sir.
Mm-hmm. So what do you think?
Sir, it could be, sir. Sir, what is the age of the patient, sir? 40 years, sir. So, sir,
Mm.
uh, sir, it's blood in the endometrial cavity, sir. Hmm.
Yes. Do you want to ask about any history?
Yes, sir. Sir, the histories of sir menstrual problems, sir. Is the issue of
Yes, she
menstrual
have
problems, sir.
abdominal pain and menstrual abnormality.
So, sir, is there any obstruction, sir, uh, in the lower part, cervical region, maybe, which leads to the obstruction of the menstrual blood, sir?
Look down. Could you
Okay,
think the
sir.
obstruction will do the distension to be laterally like this? Go down, down. This is the cervix. Down,
Sir,
or
sir.
this is the vagina. This is the cervix. What do you think?
So, sir, sir, is there a so
Hmm?
actually I cannot see, sir. I'm not sure, sir. Is there any uterus? Okay. So, sir, is there a communication with the sir with uterus with the sir? Is there an abnormal communication, sir?
Do you think, do you want to ask about any history of this patient?
Sir, kindly tell me what is the history, sir?
No, no. Do you want to ask? He just, this patient presented with abdominal pain and the menstrual abnormality. Do you think to ask about any other history?
Sir, any other history, sir? Hmm. Sir, any sir history of contraceptive device, sir? Implants, sir?
No. What else?
Okay.
If I told you this patient just have a surgery, you weeks ago, what do you think?
Sir, this seems a abnormal communication, sir, but I am not sure that with this communication is leading to, sir, is this, uh, sir,
If
hmm,
if 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 I told you this patient have section, cesarean section, what do you think? What happened here? See, this is the uterus, this is the fundus from the beginning. Down, this is the
sir,
body, and this is the uterocervical junction. And from this junction, some herniation. So what do you think? Look here.
Sir,
What do you think? What happened? What happened for the myometrium here? This is the site of section. There are some herniation through it from here.
sir, is this DH sensor of the uterine wall, sir?
Yes. So what's your diagnosis? Look here. This is the uterus. There are defect here and some herniation.
So this is sir, hematoma is a sir bladder flap hematoma, sir?
No. What else? Because there are,
Sir,
see, look here. Look, there are a defect in the myometrium. Defect
sir,
and herniation. Yeah, you are
sir.
very near. It is something related to dehiscence here, but not dehiscence only. Because this is contained. Look, this herniation is still contained, not really extending within the pelvis.
Sir, sir, it's herniation. So, sir, yes. Sir, is there fishless communication, sir? There's no fishless communication with the bowel, sir. Herniation of the sir
What is the definition
content, sir.
what is the definition of mucosal herniation? What is the definition of ureteric mucosal herniation within the bladder? Ureterocele. Okay? Ureterocele.
Sir.
Here, this is the isthmus, and this is mucosal herniation. So this is isthmocele. Okay? One of the complication that came after section. See, a section is isthmocele. What happened here? It is unfamiliar, despite not a big deal and not a difficult case, but because it is non-familiar for us, most of us will not think about it. What happened here, my colleague? Thank you, doctor, so much. What happened? If we follow, we will see some tubular structure. So when you think about it, may be hemosalpinx, you will write. It may be logic. But if you follow it, it is continuous with the endometrial cavity. If you look here, look, you will see some defect here, sort of defect in the myometrium. So herniation of the endometrial content through a defect here, but it is not extending outside to fill the pelvis, so it is still contained. So it is isthmocele. It may be, if you told the exam doctor, it may be dehiscence of the C-section. Okay, you still not very far, but at least you must ask about history of section. Why? Because it is in the exact location of the CS section. Okay, thank you, doctor, so much. The answer is here. Cesarean section is more sealed. Next and the last. Next and the last.
Hello, sir.
Next. Yeah, welcome. Doctor, this patient is 25-year-old female patient presented with swelling of the foot.
Okay, sir.
What?
Yes, sir.
What is the name of this sequence? This is the
So
first
PDFS
question.
sequence, sir.
What is the name of
I'm
the?
presented with the MRI axial PDFS sequence of the ankle joint.
Oh,
And
one second.
with the
One second. One second. This is the first question at all in the Viva. So it is better that you start with mentioning the sequence like our colleague do, like our colleague did. It is very pleasant from your side. Don't wait the examiner to ask you this about the sequence as a first question. Go on.
Yes, sir. So in the visualized axial PDFS sequences of the ankle joint, I can see that there is a subtle marrow edema which is noted along the articular surface of the navicular with another accessory os which is seen inferior to it. So marrow edema is seen in the accessory os as well as in the navicular bone with subtle cartilage cortical irregularity noted at this surface. So considering this accessory bone to be an accessory os navicular, and this marrow edema may be secondary to os navicular syndrome, that is communication pseudoarthrosis formation between the os navicular as well as the navicular bone, sir.
Excellent. Which type of os navicular? This one. How many types you know?
So that I am not sure about types.
How many types?
Types of os navicular, sir, I just know that there is a classification called GEAST classification, sir, in which it can be either bifurcate or it can be ostibial. I'm not really sure, sir. I know
Anyway,
that there is a classification which is called as GEAST classification, and which is used
yeah.
for this accessory navicular bone.
What else? Okay, there are another finding. Could you have a look?
Yes, sir. I can see that along the medial aspect, there is a subtle mass effect which is noted about on the tibialis anterior tendon also, sir.
Yes.
Yeah, so the cause of pain for the patient might be because of the pseudoarthrosis between the os navicular as well as the mass effect which is present over the tibialis anterior tendon. I'm
What
also
else?
trying to, sir.
What else? Okay. What else?
Yes, sir. I'm trying to visualize other medial and lateral ankle ligaments, and I can see that the anterior talofibular ligament is appearing a little thickened, but it is appearing intact. A mild effusion is noted around the joint space. Some sir, it's not scrolling for me anymore, sir.
No. Look at these slides and tell me. Hello?
Oh, yes, sir. Yes, sir. I'm just trying to look at the slice. Mm. Is it a deltoid ligament sprain which is present, sir, in this patient?
Yeah, there are a pathology here. What do you think?
Sir, I think there is a sprain of the superficial deltoid ligament also, sir, and some amount of tear. Can I visualize it in the coronal sections to confirm my findings, please?
The deltoid is good. What else?
Okay. Tailors. Okay. Some amount of cartilage thinning which is noted the talar dome. Um, no, sir. I'm unable to find anything else.
Okay, thank you, doctor, so much. What happened here? From the first look, she picked up the finding, despite this type of pathology is not familiar for many of us. What happened here? There are extensive edema here of the bone, and there are ossicle or accessory bone here, and there are pseudo articulation between them. So this is an extensive marrow edema and subcortical marrow changes, like cystic changes. This is all the criteria of os navicular syndrome. Okay, my colleagues, this is the navicular bone, and this is the os. So this is a syndrome called os navicular syndrome. What else here? We should look for other ligament and tendon. Here there are extension here to this tendon, tibialis posterior, tenosynovials or synovials. And what else? If you look here, this is the fibula. This is the talus. Okay. Anteriorly, this is anterior talofibular ligament, which is intact. Look at the posterior, which is very important. Very important. It looks edematous, enlarged, swollen, so there are sprain here. What else? How can we see the deltoid? The deltoid is at the medial side. Okay. The deltoid, I don't know how can you diagnose the deltoid in the axial. This is the deltoid. Okay. It looks like a little bit edematous also, but take care that the deltoid, especially the part, sometimes normally heterogeneous. What else here? I think this ankle have some sort of valgus. What is the valgus? I will facilitate for you. Valgus, that the leg axis do like this. Okay. 1 second. Here. If the leg do like this is varus. If do like this, yeah, I mean, this is the left leg. Okay, I was explaining at the right leg. If the left leg do like this is varus. But if generally do like this is valgus. If you look here, you feel this axis with this axis looks like valgus. Why? Because the mechanism of alignment of the leg has been changed due to this severe inflammation. Okay. Besides, also some this valgus is very common with the flat foot. When the patient has flat foot, almost he has a hind feet valgus. We also must comment on this Achilles tendon. We also must comment in this one, which the plantar fascia. Again, the most confusing part is the ligament. How to be accurate about the ligament? From up, this is the fibula, this is the tibia. So anterior and posterior tibiofibular ligament. Okay? If you go down, anterior and posterior talofibular ligament. Okay? The deltoid is here at the medial, not at the lateral. And down, this is the fibulo, this one, which is deep to this peroneus muscle, the calcaneofibular ligament. Okay, my colleagues, is it clear? Because many of us is confused within the ankle. What about the tendons? Tibialis anterior, tibialis posterior. Here, extensor hallucis, then extensor digitorum. Here, extensor hallucis, then extensor digitorum. Posteriorly, the opposite. This one is flexor digitorum, and this is the flexor hallucis. Is it clear? The Achilles tendon must be like this, concave. If you see it convex, it means tendinosis. Any question in this ankle? Anyone has question? Is it clear for all of you? Okay, my colleague. Also, we search
Yes,
for
I have a question, sir.
Yes.
You ask about the types of accessory navicular bones.
Yeah, 1, 2, 3. We have 1, 2, 3. 3 is the fused part. What is 3? You will find this bone completely osseously fused with this one. 1 and 2 non-fused and different from each other according to the size. The smaller one, I think less than 2 cm, something like this, or 1.5 is type 1. More than this size is type 2. I think this is type 2. Okay? So we have three types of os navicular generally. without edema and pain and the cystic changes like this is not considered syndrome. Okay, accessory navicular syndrome or os navicular syndrome. Any question, my colleagues? Okay, thank you so much. Thank you so much for our coordinator. Goodbye.